G'day. Welcome back to episode 105 of the Sports Medicine Project. We have a huge, informative, great episode coming today. But before we get into any of that, welcome to my gracious and knowledgeable co-host, Kelly.
Gracious? I haven't heard that description before.
I read it in a book this morning. Actually, I listened to it on Audible this morning. Barack was talking about
no one but me.
Yeah, so I thought it was a good descriptive word.
I like it. Gracious.
Did we speak about, when I read a word, I'm trying to use it more? A bit like how if you meet someone for the first time, if you use their name multiple times, you can remember, which I'm not very good with names. Great with faces and good with memories, but not so much with names. I'm trying to.
I don't think you're very good at memorizing
Yeah,
things.
Great memory. Memory like a hawk.
I don't think you are.
Nah.
Maybe in some things, but not others.
Yeah, I don't know.
I feel like you don't remember many things I tell you, but you remember a lot about feet.
Yeah, I remember a lot of research studies and a lot of weird statistics rather than something that you might have told me a couple of days ago. But I wonder why that is.
Selective hearing, maybe.
Well, I still hear it. I mean, you have to hear it. You don't really have a choice. That's the other thing I've been reading about is just that the conscious mind and your ability to control reality. You can't always... Like, I can't choose not to hear what you just said or interpret your words. But how you remember things, I really find that interesting. Because I can remember some things from research studies that I read 5 years ago, but I can't remember maybe something that you told me a couple of weeks ago. But anyway... We've got a good episode coming today. So this episode is with Professor Martin Sullivan from the East Coast, from Sydney, and we're talking about everything to do with Lisfranc. Now, I searched the ends of the earth. I could not find a good quality audio and video format explaining about Lisfranc injury. I just couldn't find anything. Nothing on Spotify, nothing on Apple Podcasts, nothing long format on YouTube. A couple of breakdowns, but it's like a PT or something talking about how he rehabs them.
Did we the episode that we did that touched on Lisfranc injuries, was that just us chatting or was that with Dr. Ken?
I think we did briefly mention it with Dr. Ken's episode, which has been a really popular episode. So go back. I think we did 2 episodes. No, sorry, we've done 4 episodes in 4 parts. One purely just on syndesmosis and Dr. Stephen Ken is a foot and ankle orthopedic surgeon, and then also one just generally on foot and ankle surgery.
That was when we touched on Lisfranc's.
Yeah, but this episode is dedicated to...
Just Lisfranc.
Yeah, just Lisfranc. So diagnoses, what is the complex of the Lisfranc? What does it do? What should we do post-operatively? What does the surgery involve? All the questions that you really do want to know. But because it doesn't present that often, it's really hard to get a good grasp experience-wise. Like how many would you see acutely come into the clinic?
I would often not see any acutely. Oh, actually, yeah, I lie. One of them had come in post-operatively, or 2 of them maybe had come in post-operatively, and then 2 had injured it during footy, which we sent on. Yeah. Yeah,
so it talks about the difference
that was over the last year or 2 that I
low
can think of.
And high energy. Is high energy classified? So because we talk about the mechanism of action as well, but if you pivot and twist, is that classified as a high energy?
No,
so
high energy is like car accident
trauma.
Yeah.
So that would still be low energy.
The first one.
Yeah. Yeah, because even in the research, they classify it as both either. And it's obviously difficult because the high energy is going to have some other associated things like fractures, which we talk about in the episode. But before we get to that, our general housekeeping, of course, where we go through our weeks clinically, talk about any research that we read. But if you are new to podcasts or if you're new to technology, there is a feature that we have added to our last 5 podcasts. Well, I have added it in. There are chapters. So what you can do, and tell you a funny story, I'm going to get your real first impression, I haven't told you yet. You can click through down the bottom. If you click chapter, it skips out Kelly and I speaking and then gets to our distinguished guest. So if you want to do that, you can do that. Otherwise, we're probably going to speak for the next 20 to 30 minutes about clinical cases Monday to Friday that we see and how we manage them, and also talk about some of the research that we read and talk about some other just really pure clinical things. But if you don't want to hear that, you can skip right to chapters.
How do you do that?
So down the bottom, there's a 3 little lines, and if you click that, it'll say that the chapter. So if you go back an episode, there's a chapter of me introducing who Dr. Stacey Sims is, and that was our previous guest. And then you can actually get to when we say, hello, welcome to that.
How cool is that?
Yeah. Trying to make it as easy as possible. If you don't want to hear our voices, I don't blame you. But wanted to tell you a funny story. on each episode, we have a option to ask a question. So I have put in there, has this changed anything that you've done clinically? And very, very rarely do we ever get any response. We've had a couple on Dr. Rich Willie's episode, a couple on Dr. Keith Barr's episode. But we had this one a while ago. I think it might have been maybe with Ebony. It was with someone, but I get a notification to my email and I just hadn't checked it. The clinical thing was, I love when you guys have a guest on, but I really hate when you guys speak before it. Can you just skip that out? I think that'll make the podcast better.
Did they?
Yeah. I didn't have a profile or anything, and I was like, oh, damn. But that was only one person said that, so I'm sorry to say I'm not taking on your feedback. But that was quite funny, I thought.
I feel like I don't want to carry on now.
No, it was one person, and I really feel like it was a bot. Well,
bot?
No, it wasn't a bot. It was a real person. It was definitely written by a real person. But we've had some really good feedback to counteract that on people really enjoying when we discuss our clinical life and the real life scenarios that we face every day in our clinical reasoning, which seems to be really important and people want to hear. Which is good. If you are also someone that loves things clinical, and we've spoken about this before, there's a link in our show notes. We have our Patreon set up, and we've just added 2 videos there. One is talking about how to return someone from a running injury or manage their running load while they're training. So we're just talking about things to modify frequency and volume and intensity, how we classify if someone's high or low risk based off their personality and their injury. And then we've attached some templates that you can use and you can modify on the fly to return someone. So there's an uphill one, there's a downhill one, there's a 4-week one,
downhill.
a 5-week one, 6-week one.
I don't remember there being a downhill.
No downhill? No, so just uphill, just 6-week, 5-week, and 4-week, which is really good. So I added the 5-week in because I know you've got the 4 and 6-week. And you can modify these in real time in the clinic. So it is just a template. And we always say that you can't just use a template for everybody, but that comes along in the Patreon. And then another video, which I've added, is a 25-minute review on the literature and systematic review of fibromas and what they are, what imaging is best for them, how do we rule out if they are potentially something like a sarcoma, something cancerous or malignant. And then secondary to that is a video of me going through a foot orthoses script to unload them, because they typically do quite well with some plantar unloading deflection wise. So just talking about the arch contouring, what I did in the script and why, and the biomechanical reasons for that, which I think is pretty unique. I wish I had that when I was a new grad.
I might have to go watch that.
Yeah, you'd never
Although I don't see fibromas that often.
Yeah, and you need to be able to, it's really specific to podiatry. But the running one is a bit more broadly based. Cool. So you want to go through your week? Oh, actually, one thing I had to say that before, because we've been a couple of weeks away. So I wanted to give a shout out to all the podiatrists listening that I met up in SEPA. As I said before, I'm not great with names, but I definitely remember the people, just having someone come up and speaking and then mentioning they listened to the podcast or they really enjoy the podcast and they enjoy having information like this accessible in their phone with no barrier, financial or time other than listening to it, was just really cool. And I really, really appreciate that. It really means a lot. Yeah, that is so cool. Like, I've had a few people come up to me and they're like, I recognize your voice, which is quite funny. It's a weird feeling to sort of have, but it's good. Yeah, it's great. It's great. And of course we would, well, I say that, I mean, even I've said this multiple times. Of course, we wouldn't do it without all these lovely listeners, but I probably still would do it even if we had one listener, because you get to speak to people like this and you learn so much. Yeah. I quite look forward. I look forward to recording these podcasts, particularly with guests. I feel like it's, it definitely gives us that. What about you and I? We get together and we have a little yarn. I actually do quite enjoy these discussions. Yeah. Except I'm glad you're telling me that after 105 episodes. Do you like them? Yeah. I love them. This is the greatest thing that ever has happened to me, this podcast. No, I'm kidding. It is really fun. Nice to get some clinical thoughts out through there. Yeah. Yeah, it's good. All right, let's run through the week. Monday to Thursday, because Fridays are Friday off. More. Monday, I had a patient who had seen 2 physios previously, and I just wanted to... What are you doing? I'm listening to you. Oh, you're doing a weird thing with your I was having a sip of my tea. It's cold, my brother.
The power of hindsight when you're seeing a patient who has seen previous physios. You have such a high chance of succeeding if you really listen to the person and what they want and what they feel like they didn't get from the previous physios. So this particular person had knee pain and had seen 2 previous physios, and they kept highlighting the fact that they were getting a lot of hamstring tightness, and their idea or their thought on what their pain was caused by or a contributing factor to it was the fact that their hamstrings felt so tight all the time, and they felt like the previous physios hadn't addressed that at all. So on that initial consult, it was very easy to get buy-in by simply giving this person some hamstring stretches. It's probably not something that I would normally do for someone with just knee pain.
Yeah.
But given what they were really concerned about and what they felt was contributing to it and what they felt like they had missed out on from their previous physios, it was such a low-hanging fruit to get that little bit of trust, build that rapport, get them to buy into what I was then eventually going to tell them by simply giving them hamstring stretch.
Yeah, that's good. I heard a good quote at the CIFMA conference. If you listen to someone speak, they'll tell you what's wrong. If you listen long enough, they'll tell you how to fix it.
Yeah,
or
exactly.
how to help them.
That's perfect. That's exactly summarizes that perfectly, I'd say.
I do like this point, and I've spoken on the socials about this quite a lot, and we try to have as much humility as possible. I mean, you and I are always saying, in any sense, that we're not the expert. We're just out here trying to learn just like everybody else. And that power of hindsight, when you see someone that has seen a previous practitioner, when I was younger, it never sat well with me. I was always a bit quick to judge, as if they would do that or this. And then as you become more experienced, and I'm talking about my first couple of years, now I really just, and I say this out loud with people, great, I've got the benefit of hindsight. You've seen someone else and you've tried this and it hasn't worked. Let's just try this, because I know time and time again, that scenario is going to happen to me as well, where someone sees me, something doesn't go right, or we don't gel, or I do something. And you slowly become, or I have become okay with that, knowing that I'm always trying to reduce that happening. But they're going to see someone else go, oh yeah, saw Blake and just didn't work, didn't do that. And they're going to probably try the opposite or something else, and it may work. So you just got to have the humility. And I think my learning from that is I never in any sense talk about another practitioner in a bad light or in bad faith ever, regardless of whatever's being done, because I don't know the context, I don't know the story or anything. And that's a general rule and principle for me.
So this scenario, for sure, they had been given some really good rehab. So the physios were giving them some glute bridges, some calf raises, a really comprehensive loading program, some wall sits, some sit to stands, all the things that you would for this particular type of condition. So they'd been doing everything that I would have done. It's just that the patient had this feeling that it wasn't complete because of this one thing.
And
so
how is it when they tell you, what's happening, going, oh, I'm so glad you've seen someone else, because that's exactly what I would have done.
Yeah,
you know what I mean?
Exactly.
So it's interesting. I like that.
Yeah.
It's good. It's good. Tuesday, roll us in. So you've woken up, you do Tuesday session, you're a little bit tired, but you've rolled into this one.
To my Tuesday. Yeah, patients, I'm going a bit neg here. Patients that just don't want to be there. And they don't, they tell you that they haven't done anything that you've told them to do. They tell you that it hasn't changed their symptoms. They tell you that they're actually not going to do anything that you do tell them to do, and they're probably not going to come back. I'm like, why come? I don't care. You're not doing this for me. You're trying to do this. You're doing this to make yourself feel better that you've come to a physio appointment. But that's not going to change anything.
Yeah. Are these private, generally third party?
Usually third party.
Yeah.
Usually third party. In this particular case, it was private, but I would say that this particular archetype of person I would suggest is generally third party. But yeah, no, this was private paying. They paid the full money for it, that session, to tell me that they had not done anything, had no intention of doing anything, and had no intention of coming back.
Yeah, that's challenging. Because you can very easily just think, well, is it on me for not being motivating or showing them how to be able to reach their goal? You can have both sides of that. How would you... It's really hard to assess.
I feel like there's a line, though.
There is a line, I agree.
If I'm not there to motivate you, if you've got a painful problem... yeah, that's on you.
Yeah, but you are a facilitator in a way. Like if you're, as an example, if someone has a really
probably
persistent...
depend. Yeah, this wasn't a persistent problem. This was like an acute little thing that had flared up, and I had not so much bandwidth for.
Yeah, it is challenging because you want people to be... I have this problem all the time of once people are doing better or close to, trying to show them the importance of sticking with some consistent movement for the long term. So if you've had a bone stress injury or a tendon injury or you've had some heel pain, it's probably good that you just do some calf raises for the long term, even once it's better.
For sure.
And then I think to myself, it is on me to show you why that's important. But I always used to blame myself. Like if they're not compliant or they don't, I'm like, it was my fault. I should have been able to show them better. But you are right. Sometimes you can do everything on earth and you just doesn't seem to help.
Yeah. No, this wasn't a condition that I felt like there was any risk associated with them, I guess, not persisting through. It was, but yeah, it's just one that
It's hard not to blame yourself, isn't it? Do you find, or you're okay with it?
I feel like I didn't really care.
What about when you were a younger clinician?
But definitely. So definitely when I was younger, that's something that probably would have irked me and I would have taken it to heart. I don't think that was the case in this scenario.
Yeah, I love Ray Dalio's quote on this. He talks about, everything in life is really just going to be another one of those. So when these things happen, like this is bound to happen sometime in the future, having some kind of solution or thing to think about when that does happen. And he talked to other senior people and they're like, yeah, those things happen and maybe just become...
It's like a pick your battles situation. Like I'd way rather battle through someone that I think needs to carry through some sort of rehab following a bone stress injury or a tendon injury or persistent low back pain. In other scenarios, I think that you just save your breath kind of thing.
Yeah, you've only got so much energy to give.
Yeah, exactly.
I mean, if you're a health professional listening to this, which you very likely are, you just deserve a pat on the back because it's a lot of energy and a lot of time that you have to give to people, and it's multiple people, personalities over the time. I mean, I think of even some of the orthopedic surgeons that we've had on the podcast. I mean, some of the conversations they're having, I guess it's all relative, but those conversations would be very difficult. And you're having multiple ones a day where people are like, you're the last stop to help this person. So, if you're a health professional, just good on you.
Good job. Kudos to you.
Wednesday,
one of my absolute favourite clients decided that they're going to start building towards a 100-kilometre ultra run, which is 12 months away.
Why did you say client instead of patient when you said patient before?
I don't know. I just mix and match. Does it matter?
Nah. I don't know. Were you like patient or client?
It probably depends on the context. In my head, this person is more of a client than a patient.
Yeah. Okay.
Yeah, I don't know. This, so building to an ultra run, 100K is 12 months out. So we were having a discussion around how to periodize the next 12 months, which is kind of fun to map that out.
Resistance or both?
Both. Yeah. And speed work and when that starts to drop off and when to start to build volume and what base building should look like. And the importance of strength training and when that should be the priority and when that might drop off and sort of those things, which is quite fun.
So question for someone like that, and let's say they have had a history of injury, how often are you going to schedule the resistance training in the week? And I want to know why on a clinical level. And 2, how do you explain that to someone?
So we had a chat about potentially upping the resistance training from 2 times a week to 3 times a week at the moment for the next 6 months, roughly. Seeing if we can start to push a little bit more of that strength and that strong foundation to then build volume from. This would be a time to use that as a real capacity building from a capacity building standpoint. And also we would anticipate that the strength training is probably going to drop off at some point when you're building towards a 100-kilometre ultra. So sort of laying that down as much as possible now while the mileage isn't so high and there is a little bit more energy to give towards that. And then we'd anticipate that might start to drop off as the volume for the running starts to really increase. Yeah.
I know that, in the context of injury, and we're going to talk about that in my week, but some quality research, again, it's in animal models mostly, around how bone loading is best done with smaller sessions, more frequent, spaced apart. I was listening to one of Keith Barr's lectures and he was talking about they may be seeing, or he is seeing in the lab, and again, in the lab, in their human, but in lab-grown tendons, but they're seeing similar things in tendons where short bouts of activity potentially are better, and what they're classifying as better is like the gene expression of extracellular matrix and collagen. So when I'm thinking about this now, I'm like, it probably is better to do a shorter session 3 times a week for a runner, and potentially it is less fatiguing because you're doing a shorter session. But I was always of the theory to do more, and then I've kind of come back to less, and now I'm kind of in the middle with that.
I think it just depends on the person and them being able to get there to the gym ultimately, because it is a bit of a
I agree.
extra point, like an extra time out of the week to get to the gym, drive there, all of those sorts of things, and get the session done.
Yeah, walk in the door kind of stuff. It is. I forget that because the gym is obviously at work.
Yeah, well, it does take time to do those things. So sometimes it's just not realistic. But you're right, maybe it's worthwhile having, 2 good gym sessions and then a home-based program.
Yeah, and I'm assuming like most optimal, best case scenario. But you can do some good stuff from home. I mean, you can do some plyos. I wish that... I mean, it's not that expensive. And I've had patients buy stuff from Kmart. Like, they can get a 12.5 kilo dumbbell and a stair for like $30 to $40. And that's probably going to serve them pretty well long term.
What do you need a stair for?
So you can do some, or in my context, because I'm giving lots of calf raises.
Oh, most people would have a little step at home.
You'd be surprised. Or the stair is not somewhere that's that accessible. And
so just to make it easier to get done,
yes,
like
and
put it right next to the end of the kitchen bench. Like if we had one on the end of our kitchen bench,
would be good. Because if it's outside...
Do you reckon we'd even do it? I don't even think I would.
No, I do it enough at work. But if it's outside, like, yeah, I've got stairs at home. Are you going to go outside at 6 p.m. and do your heavy calf raises? Probably not. But if it's inside, yeah.
That's true. That's very true.
Thursday.
And Thursday... just was running an S&C session with a patient who was newer to strength training, and I just wanted to put it out there as a little bit of a reminder that when you are taking someone through deadlifts for the first time, or if they haven't done them for a while, remind them that DOMS or muscle soreness in your low back is pretty normal after doing deadlifts for the first time or after a long period of time off. You are using your back extensor muscles during a deadlift, and they will start to fatigue at some point if you are starting to push into a bit of fatigue. And it's common to have a bit of muscle soreness through that region. I really like to emphasize the point that it is muscle soreness, just like you would get sore quads after doing squats or sore glutes after doing lunges or something like that. Not to be concerned that you've got back pain.
Yeah, I really like the feeling of DOMS. I can get why some people don't, but I
think when people get it in their back, sometimes when they're already a little bit concerned about doing deadlifts, they get a bit concerned if they've got that feeling of soreness around their back.
Yeah.
And some people can't differentiate between DOMS and pain.
Having a back pump is pretty good. It doesn't have
I got a pump the other day. Did I tell you that?
Yeah, you told me.
Blake always asks me if I get a pump from the gym, and I always say no. But the other day I did, and I think it's because I did more than 6 repetitions. My muscles were just burning.
Pump is good. I remember being just a young 16-year-old boy. I went to, maybe I've never mentioned this on the podcast, but I went to an all-boys boarding school, and we used to go to the gym in the morning or the afternoon. The afternoon was better session, and getting a pump in the gym, that was the best thing to ever happen. It was so good.
In your biceps?
Yeah, because as you're a 16-year-old boy, all you do is arms. We used to finish...
And chest?
Yeah, we used to finish... So we would just gather around the bench press and just lift heavy. And then when...
And then just do like drop sets of bicep curls.
Yeah, we used to do 21s at the end of when there's 5 minutes to go. You would do 7 reps in the inner 33% range, and then 7 in like 33 to 66, and then full range. And I used to get the biggest pump. And
that would burn.
Yeah, never did any carbs ever.
Yeah,
I don't know how I never got a stress injury.
I've been in a bit of a gym slump, as I often do go through, and Nikki wrote me a program, and she gave me 3 sets of 15 for biceps. I was like, come on.
Yeah,
I don't need a bicep.
No, sorry, that's a lot of reps.
It was a lot of reps. I picked up 6 kilo dumbbells and I could barely get through it. I was like, man, I am a weakling.
A good mate of mine, I definitely don't think he listened to this, Dusty Ward. Him and I used to gym a lot when I first started my degree. This is a long time ago. And he would always give me shit because I was following this really high rep, high volume training program, and it was 5 sets of 20, and it was super
5 sets of 20.
Yeah, and I'm a pretty tall, wide guy, and I always should have just focused on strength because it's so much better for you. But I was just going through, I need to get toned. I'm just doing these high reps. It was so fatiguing. Like, you imagine doing
That's
5
like a
sets
body
of 20.
pump class.
Yeah,
I
5
used to
sets of
teach
20
those things.
squat. Like, I remember for the curls, I'd be getting down to almost no weight, which is crazy.
How much rest between?
It was like a minute.
And then you go again.
Yeah.
You'd be at the gym for like 3 hours.
We were there for a while, and it was so fatiguing by the end of it, just like neurological fatigue. But Friday night before going out, arms. Friday, I have a playlist on my Spotify called Friday Arms. It's so good. It's just awesome. It was good. Anyway, off topic.
Moving on.
Getting to a pump.
On to your week.
Yeah, so Monday to Friday, I have 5 days a week, but Monday was a good win. Just it still surprises me how just different systemic health conditions can play into the musculoskeletal system, and when we think of someone holistically and what can be going on, so this person has hypermobility and EDS and some other connective tissue disorders, and a really flexible subtalar joint, tarsometatarsal, just flexible kind of below the ankle, and had been referred for some arch supports because they were getting kind of medial ankle pain to knee pain and just general fatigue pain that was pretty diffuse, and hadn't worn anything in their shoes before. They were seeing someone else, some really quality rehab, and they were just coming to see me for really foot orthoses and with shoes. Now, before you think, as if you're just doing foot orthoses, there is good quality research to say when people have fatigue and pain with these connective tissue disorder in kids and then adults, that external supports and braces can really help, whether it be the knee or the foot and the ankle. And what we're thinking long term is, if I can put something in the shoe with a good shoe, and they're able to do more, less fatigue, do more of their exercise physiology, and just have a better quality of life, and that's a huge win. So made an innersole. It was a custom innersole, and we used, getting pretty podiatry talk with this, but it's interesting. So we use something called a medial flare, which is a raising of the medial part of the arch, and what happens is it will come up and actually, almost like a C, come up and hug the arch, and the idea is to really make contouring with the foot and reduce any deformation of the arch. So really to reduce that midfoot pronation or subtalar joint pronation, whichever you want to say. And we went quite aggressive with that, knowing that I can adjust and reduce that support in through there. And pretty neutral foot type, pretty unremarkable biomechanics, but really hyper flexible. And the initial reaction was, this feels amazing. And rarely does that really happen. Someone says, it feels comfortable, and we talk about comfort and fitting and things like that, but this person just said it felt really, really good, and just having so much support. And I was surprised at how much material and stiffness was there, how much better this felt for the foot. So just makes me think, again, how if we have these kind of set ideas and principles and bias for people, you could really miss out on wins like this. If I was a bit more inclined the other way, like, oh, no, you don't need supports, don't worry about shoes, let's just focus on building your foot strength, we might have never had a win like this. And I'm going to see this person for a review in a few weeks. And that isn't to say that things will maybe not have changed, but yeah, those things can happen.
I was having a chat with my colleagues at work on Tuesday this week, and we were just discussing when biomechanics is really important, and when you do need to be considering a lot of these types of things. And there are certainly conditions where you really want to be considering where that loading is being distributed, how it's being distributed, does it relate to the person's painful problem, how is that going to relate to them being able to perform in any functional tasks or sports or activities that they find meaningful. I think it's really important to be asking yourself those questions, and if it is a factor, then there's certainly no harm in referring on for more
just external braces or external supports, like whether it be AFOs or Ritchie braces or shoes or orthotics or something for the knee or something for the wrist. But just to be clear, this isn't a case that happens all the time and people come in and just put these things in and everyone's amazing. I'm not saying that at all, but it would just remind me, because I've had a couple of people book online, funnily enough, from different parts of Australia that have found me on like a barefoot website. I don't know if I've told you this, where the people have linked me as someone that
treats barefoot style.
well, they encompass the kind of barefoot narrative, which is really, I don't even like to use that term.
Do you feel like you're a bit of a barefoot boy?
No, it's just the tissue capacity narrative that I really enjoy. Like, people can be strong and robust, but I've had a couple of people book online, and then it's the opposite. They've had, and that comes back to you talk about the benefit of hindsight, where I've done a couple of telehealths lately, and people have had the opposite effect, where they've had inner soles and shoes where like, I want to come out of it. How can I make my feet and below knee strong? And we go that way and go through some more rehab. But yeah, I thought that was interesting. Tuesday, it's always tricky managing, and I really love your opinion on this, where you're seeing injuries on either side and one is limiting by the other. So someone with a kind of TMT synovitis joint irritation, but a persistent Achilles issue on the other side. So it's very difficult to load because you're going to flare one up. And the kind of TMT synovitis has a relatively okay prognosis, but it's just difficult to offload because of where it is in the midfoot. And this person spends a lot of time on their feet. They're getting a lot of joint irritation. They're putting a lot of stress through there, and they want to get back to running and moving. And this Achilles has been going on for a while, and we haven't done, well, they hadn't have done any loading on that, so we need to start on that. But it's difficult, hey?
Yeah, I think I see a lot of it because treating the whole body, which you don't do, they do tend to move on from one area to the other, and it can be hard to manage both. A lot of the time, you're asking yourself, do you need to expose, or do you need to avoid, I suppose, is the things that you're sort of asking yourself about injury management when you're dealing with two different areas. And if they both need to be exposed to load, then that makes it a little bit easier, because obviously you're just starting to capacity build in both areas. If one needs to be loaded and then the other one needs to be, or one needs to be exposed and the other needs to be avoided.
And they're related because obviously calf and...
That's tricky, of course. But I think there are ways that you can still work around it, or potentially, if you can't, I'd say that the one that you do first is the one that needs to be avoided. So you settle it down first and then you start gradually building.
Yeah, and that's what we're focused on. So because it is more the midfoot, I don't know... I don't know if this is a clinical test, but when people have what do you call interjoint? Not intercapsular. Interarticular is interjoint. When people have like intraarticular discomfort in the midfoot, do you find that you can't actually palpate any discomfort? But if you...
I don't know what that they have intraarticular...
Well, they're like, say, I've got pain across the top of my midfoot and it's pretty diffuse, or it is relatively in this area. I'm finding as a clinical test that, because in my mind I'm like, great, how can I make those joints compress and come together? And if someone rises and extends their big toe and comes up on their forefoot, what is going to happen is you're going to get a shortening between the calc and the first mat. The foot comes together to really essentially lock to a degree. Peroneus longus brings the CCJ over, you get the foot coming together, so you get increased compartment pressure in the joint, and that seems to bring on the discomfort. So in this case, I'm like, oh, that's going to be great to test, because no real pain to palpate, but internally when we did that calf raise, like,
but you can think about the things that would be aggravated by doing that same movement.
What would be in the midfoot that would be aggravated by that?
Is there a few like burses or something like that, or
not
a
really.
Tendon that's getting...
Well, not on top, because the only tendons are the extensors and the tibia, and you're not loading the tendon. Because in theory, yes, you're going to be elongating the tendon because your ankle joint is going to plantarflex, but that's not a high tendon load. So you're not loading the tendon, and there's nothing really more.
What if it's the sheath?
Yeah, it could be. It could be the sheath, but it doesn't. It's the clinical history doesn't match up with the sheath, and I haven't seen. Doesn't mean it doesn't exist. I haven't seen a.
Or what about bone stress?
Wait. I haven't seen an extensor or tibial sheath where it runs over the top of the midfoot. I've seen it across the ankle joint, a bit further up, but not across the top of the midfoot. Could be a bone stress, but it doesn't fit it doesn't fit the clinical history, and 2, you would be able to palpate a midfoot bone stress injury.
Did you scan it then to confirm?
Well, it didn't fit. It wasn't a bone stress.
No. I mean, to confirm that it was a intra-articular like a synovitis situation or something.
Well, what scan am I going to get? I'm not going to send them... Well, an X-ray is not going to show me.
Not going to send them for a...
Well, an ultrasound's not going to show me much really either.
Am I right?
Well,
Don't need to.
Well, it's not really worth, one, the investment and then the time to go and get it, where I think I can use my clinical history.
Yeah.
Yeah, or my clinical signs and tests. But I don't know if that's a test.
Do you need to
ask some more people that question.
Do you need to completely offload a joint?
No, these ones, it's just more irritable. Like whether it be, because you've got bone and bone come together, you've got synovial fluid in there, you've got the synovium joint capsule. So whether they've got some synovitis within there, whether it be the actual fluid or some thickened synovium, or the actual joint capsule has some damage.
I think that makes sense. That sounds like you've thought that through quite a lot, and it sounds like you've considered any...
Just I think it through doesn't make it right.
No, I know, but
but
you have like clinically reasoned that well, and you've considered differential diagnoses.
Yeah, true.
Yeah.
We are up to Wednesday.
Wednesday.
Yeah, Wednesday.
I don't like the whole Tuesday, Wednesday. I gotta say it.
Tuesday, Wednesday. You want me to say? Yeah,
Mm.
Tuesday. Wednesday. Typical insertional Achilles. But got to learn a bit again from Dr. Emily Rio up at the CPRO conference, who's also been on the podcast, but just reinforces a lot of the things that we already typically know about those Achilles. Is they get most irritated with the dorsiflexion, because that's going to increase the compressive load of the insertional Achilles and the retrocalc. So trying to avoid that is a good reduction in provocative load. And then otherwise, we didn't start with probably their current tolerance. So they could actually do some double leg jumping and feel okay. They had some calf atrophy, had some unilateral weakness as well, and calf endurance tests, all that kind of thing. But we're just going to focus on doing some consistent calf loading twice a day for the next 2 weeks. So just some double leg raises, just trying to get in the habit and consistency. And I've had a couple where obviously the stimulus is a lot lower to what their actual tolerance is. And this one I've seen them for the first time because they haven't done anything like that at all. And they've come back and like, yeah, I'm 10 to 15% better just from doing that. And they obviously haven't done the heavy loading or the plyometrics, and them just doing some calf raises has helped. But on the flip side, I've also had people come back and it made no difference or be a little bit worse. So I'm not saying that's the answer.
Yeah, it would depend on what stage they're up to for rehab, but that would make sense from a
habituation.
Impacting.
Yeah, but it's just good to try and get the habit in, because you're constantly trying to say with these persistent Achilles injuries that it's going to be a long time.
Yeah, good one.
Yeah, I can tell when you want to get going because you're real sure like, yep, great.
Well, you
good.
Do yap a bit though.
Yeah, I thought you said just
me
before
like
you
5
enjoyed
minutes
it.
to go through my weekly review, and you've got like 30 for yours.
I was asking heaps of questions. So you said that you enjoy when we sit down and have it.
Yeah, I do.
Well,
I just don't want to take away from Martin though. His conversation was so good,
but we're not taking away. We've got the chapters. We said that at the start. We've got the chapters. People, probably 95% of listeners aren't even hearing this right now.
You've got to cook burgers, he said.
Yeah. We'll talk about that later. Either one of us can do it. Doesn't matter. Either you are.
He said you aren't cooking.
Anyway, so Thursday, just the Shockwave machine. I've had it on my ITB, and I'm not saying that Shockwave is a panacea, but you have these cases here and there. Probably, I've had 2 in the last 6 months where they've had persistent heel pain. They've done everything else right, and the only thing that we changed was the person that was seeing them had said, "Oh, why don't you go and try some Shockwave with the guys and see how you go." And coming in, confirm, this seems to be what's going on. This is how the Shockwave works. Generally, this is what the research says. This is how long we do it for. This is the costs involved. This is the time involved. These are potential risk. All that stuff that you talk about. And this person, within 4 weeks, is almost 100%. And they were probably about 65% when they saw me a month ago. And the research would suggest once a week for 4 weeks. if they are getting a significant improvement, you can go up to 6 sessions, but very, very rarely do we do that. Have a 2-month break, and then you can restart that. But this person, we're going to do 5 sessions, but had just done really well. And it's just, I mean, why? Why would it improve so much? Because, I mean, you can talk about natural history, yes. You can talk about the idea of just having a treatment, seeing someone, getting another set of eyes, all the contextual things that happen in healthcare. But that's the only thing that's changed. Oh, we put some heel lifts in. Shoes.
There's no harm, really. Like, apart from the fact that it hurts a bit, there's no real harm in trying it. So what's the downside, I think? So if you have gone through the rehab side of things and the offloading and the easier things that you can do or start to incorporate into the rehab program, and as you said, they're at that 60-70% mark, then why not give it a go?
Yeah, it's just the
I still don't get it. My mum asked me, because she listened to the Stacey Sims podcast, she asked what shockwave is. I said, I don't know.
She should come down and give her a shot.
For what?
I don't know.
For a foot. She's got that foot thing.
Oh, yeah. Text me about it. And she never replied to me.
Well, she's an example of someone who, like, wants advice, but then won't actually do it.
Instead of this big detailed voice message, no reply. She will listen to this too. I don't think we did.
I don't think she will. I don't know if the Lisfranc will get it going.
We'll get a text in a couple of days. But it is interesting. I mean, on that, yes, there's no risk associated with it, but it's not an excuse, but I don't like to lean on that because you
could pull that on anything.
You pull it on anything. Yeah. Like, oh, listen.
Just go get a massage.
You can come back
and try some acupuncture. Just try some dry needling. Next minute, they've spent thousands and thousands of dollars on things that don't work.
Yeah, I mean, I probably shoot myself in the foot a little bit. I mean, I just need to get the communication stuff every time. I'm like, I need to, the best thing that I can work on, everything holistically, but communication of trying to explain, because I'm always upfront with what potentially could happen. There is the risk of it potentially getting worse, although the literature shows a very, very small rate. I mean, there's the cost involved is a big one as well. I mean, we don't charge much extra for it. There's the time and energy involved, but there's also the fact that if someone's coming back to see you weekly for 4 weeks, what does that even mean in the context? And,
just like that contact with the health professional.
Or someone sees another health professional 3 times a week for 8 weeks and sells them a payment plan. It's like, oh, it's not invasive or anything like that. It's like, that's, not the case. Maybe just overthink it. Anyway, on the last day, hopefully don't fall asleep.
Christmas.
So, have you heard, I'm going to ask you this, you can see up on the screen, do you know what an adventitial bursa is?
Something to do with like friction
in
the foot, the joints, what are they called?
Joint space.
Of your tarsals.
Well, you can have adventitial bursts in all parts of the body, but maybe we should ask this to every single person that we come on. Could you imagine like a sports doctor versus a GP versus a rheumatologist explaining the question I'm about to ask you? So you've diagnosed someone with some form of bursitis. How do you explain what a bursa is? Give me any analogy you use. Do you get the whiteboard out? Do you pull out a little fluid-filled sack that you keep on you? Tell me.
I often just say that we've got a bursa, and we've got bursas in all of the joints in our body. They're essentially a fluid-filled sack that's designed...
Not in the joints.
Around the joints.
Around the joint, yeah.
They're essentially a fluid-filled sack that's designed to minimize friction and work as a shock absorber.
Oh, yeah. Nice.
And they become a bit inflamed and irritated sometimes.
Do you use any other analogies?
No, not usually. Maybe I would have in the past, but I feel like I keep it to that. What do you say?
I get the whiteboard out.
Get a balloon, a water balloon, and then throw it and say,
this is your bursa right now, exploded. No, what I usually get the whiteboard out. So yeah, it's like a balloon. It's filled with fluid. And it allows your tendons and muscles to glide, and it just helps reduce some of that friction and shear. But I really like this analogy, and I heard this one from the one and only Jay Smith. He explains it like when you're coming into the harbour you see a buoy. The buoy's going to stop the ship from bouncing into the deck, into the dock. And so the ship comes across, it's trying to bump into the dock, but there's a little buoy there. That's like the bursa.
Like the tugboats.
Yeah, like the tugboat. So it just stops it, and it's going to help reduce some of that pressure on the dock, which would be, a bone or a muscle or a joint. So like that nice. One. But usually the whiteboard, they're like, oh, yeah. You know what I've never had happen? No one's ever said to me, oh, that's really good. That makes a lot of sense. Thanks for doing that.
It's because no one can read your writing letter.
No, they can see my pictures, but I need a bigger whiteboard is what I need. The writing is pretty ugly. Anyway, talking about adventitious bursa. So the actual definition, according to Webster's dictionary, no, I'm kidding, but the definition of them is they are similar to your normal bursa, but they're a small fluid-filled sac that's lined by a synovial membrane with an inner capillary layer of synovial fluid. So they help reduce friction, but they may be caused by or in areas of high friction and high shear forces. So the case I'm going to speak about is one that was, and it's always a differential for someone with big toe pain. You do have a bursa that sits on the medial aspect of your first metatarsal phalangeal joint, and sometimes that can get irritated from pressure from a shoe. Sometimes you can get irritated if someone potentially has a more pronated or flatter foot posture and the forces don't get dissipated through the center line of the first MPJ and more to the medial aspect. So it's almost like the head of that metatarsal sits closer to the ground and you get some compressive force in through there.
Do you have them around your Achilles?
Bursas?
No, adventitial ones.
Well, I mean...
So I feel like that's what I get.
You get that sometimes.
I get like that burning friction pain on my Achilles. I don't think it's like my tendon. I think it sounds like that.
Nah, I think, well, I mean, I guess if we look to the research as we do as clinicians, if it is more that friction and shear that contributes, you can have those forces happen within that area. So you could. I usually see them plant a foot where the forces are a little bit higher, like under a second metatarsal head. If someone has some anatomical changes, they've got a longer second met, those type of things. Or usually with someone that has some, structural deformity to their feet, and the way that they weight bear is really increasing the pressure on that side. So, someone with an adventitious burr on the medial side, and we just increased a little wedge underneath there, and it really just unloaded the pressure. So
fixed them right up.
Well, no, it didn't fix them right up. It just made it a little bit better. So it definitely wasn't this silver bullet or anything. It was just a little bit more comfortable, and I thought it would be a cool case for people as a differential, because you don't often hear about that. Like, would you think someone said, let's say Barack Obama calls you and says, hey, I've got big toe pain. What could it be? Would that come in your differentials? You're just like turf toe, sesamoids, maybe a flexor lucis, maybe some osteoarthritis, really change, that kind of thing. But you don't often think,
no, I don't. I wouldn't.
Medial burst, but they're not that common. I've seen it mostly in netballers when they change position and get compression and rub on the shoe because they're always going over on the side.
Do they often have like a bit of a callus there too?
Callus, and they do blister there, but it can be difficult to manage, because if you want the shoe to be really nice, tight fitting and give you that stability, it can be really hard because you want to take that pressure off through there, and it's difficult if you want to increase the padding around it to reduce it on it, because you end up taking up more room in the shoe. But they usually respond well if you just get them out of shoes and things.
Cool.
Yeah. All right. Well, you guys will all enjoy this episode with Professor Martin Sullivan on everything Lisfranc, and we'll speak to you next week. Before we get into this episode with Professor Martin Sullivan on everything Lisfranc, to give you some context as to what his week looks like, he is a leading international foot and ankle surgeon who is called to treat and correct many foot and ankle conditions, from the unstable ankle to Lisfranc's to syndesmosis. He looks after a wide variety of populations, from elite athletes to the everyday person. He is currently the director of the North Shore Foot and Ankle Clinic in Sydney and a consultant surgeon at St Vincent's Clinic. He was previously a consultant to the University of Sydney Sports Clinic at the Cumberland Health and Research Centre, and he is on the editorial board of the International Journal of New Techniques in the Foot and Ankle Surgery. He has numerous published studies and has been publishing for for over 20 years and is also responsible for developing the endoscopic surgical technique on insertional Achilles tendon disorders in 1996. In 1999, he was an invited guest of the American Orthopedic Foot and Ankle Society to speak on advances in arthroscope, foot and ankle surgery. Martin pioneered the rapid rehabilitation program following ankle ligament reconstruction and has an extensive experience with Australian and international elite guests. He has been involved in the education of Australian sports physio, podiatrists, physicians, as well as nurses and medical students for many years. When we speak about the Lisfranc complex, we talk about lots of different topics, but the ones that are most relevant clinically: how to diagnose, what happens when that presents to the clinic, what's it going to present like, what are some of the potential signs you may see, what does the surgery involve, what does the post-operative rehab need, and everything else you need to know to be well across the literature on Lisfranc.
Yeah, no, I mean it's a great topic. So it's obviously important to get all the current information out to everyone. I'm not sure how many listeners you have, but by way of background, when I came back from the US in 1994, if you're an athlete and you had a Lisfranc injury, essentially it was a career-ending injury, and that's if it was diagnosed. Right. So majority of them weren't diagnosed initially. Partly there was imaging, MRI wasn't around then, but just awareness. But funnily enough, I used to lecture to the physios at Cumberland when I first got back, and it's just a matter of once you show people, like anything, train them, show them. I used to get referrals from physiotherapists of Lisfranc injuries diagnosed clinically. And this is way back in the 90s. So a lot's changed since then, particularly in terms of the management.
Yeah, it's interesting that, hey, it's like once you know that to look for something, you see 10 of them in that week.
That's right. You may not have seen it, but it's seen you. But
for sure.
Yeah, it's a great topic. The ligament, as you know, it's a very strong ligament. It's got three parts to it. There's a dorsal component, a plantar component, and the interosseous. Basically the part of the ligament that connects the second metatarsal to the cuneiform, the medial cuneiform. The interosseous part is the strong part. It's the part that causes all the stability between the two. And for those it's hard at doing a podcast sort of without any diagrams or images, but essentially for all your listeners, if you think of the foot, if you think of your hand, that your thumb is the first ray or your big toe, and your fingers is the rest of your foot. And essentially that ligament connects your big toe to the rest of your foot. And if that ligament gets torn, then you've got a disconnection between the big toe and the rest of the foot. And if you think of it like that, then you can apply a lot of different ways of all the clinical ways it may present. And probably, again, if you look at books, they talk about different tests you can do, but if you just look at a patient's foot with a Lisfranc injury that's got a rupture, then their foot's going to be wider because suddenly you've got a gap between your big toe and the rest of the foot, and so it has to widen. So apart from the swelling, obviously they're going to have a lot of swelling and pain initially, but you're going to have a foot that's wider than their other foot. So you just need to obviously take off both shoes. And, if they come to my office, you want to look at both feet, and it's pretty obvious. You point out to the patient how wide that foot is. You can trace the outline of the foot on a piece of paper and measure it and compare it to the other one. But it's very simple. You just need to look with your eyes, and you can see that it's obviously a lot wider.
Does that happen relatively quickly after the injury, or does it take some time for that to develop?
Yeah, usually you can get swelling fairly quickly. Basically in the past it was diagnosed as a sprain, like a foot sprain, which, as you know, is not a diagnosis. So they had swelling there and they had pain. It varies. I mean, everybody's different in terms of pain response, but generally you will get swelling there. And in your office, if you see them afterwards, particularly say the next day or a few days later, few of the things you can do, just get them to try and stand on their toes. That's a very good provocation test, because if the joint is unstable between the big toe and the rest of the foot, then they'll have trouble doing that. Not apart from causing pain, they'll just feel like it feels weak or it feels unstable. You don't want to put words into their mouth. So, so they're simple things you can do. If you read up on it, there's a thing called a piano key test. And essentially, if you think about it, what you're doing is you're getting the second metatarsal, you're stabilizing the big toe, the first metatarsal, you stabilize that, and you press down on the second metatarsal. And like a piano key, if the ligament's been disrupted, and it can involve also the dorsal components, so not necessarily a grade 3 or complete rupture, then there'll be more movement in a dorsal plantar plane. And then you check with the other foot. So usually I'll get both their feet on my knees in my office, and I'll just check one with the other. Then I'll get them to close their eyes, and I get them to tell me what they feel. And most patients, apart from assuming it's not too painful, they'll say that it moves more if that ligament is unstable.
Why do you think they typically get missed quite a lot? And to give you some more context for our listeners, and most people that listen are health professionals, and we've got, between the podcast and our social media, a couple of thousand people each week. And when we talked about doing this topic on the socials, it was a really well-received topic because people know about them, know they're really important. But even the literature suggests that they do get missed quite a bit, similar to navicular stress fractures. They can go undiagnosed for some time. Is there a reason you think that is? Because people don't suspect it, or the tests aren't as great, or what do you think?
I think it's a combination. I think awareness. I think people are obviously more aware now because of high-profile athletes who have the injuries, gets into the media. Again, social media, what you guys are doing, podcast. Generally, the whole medical landscape has changed dramatically in the last 5 years in terms of getting information out there. I think the problem with the injury to essentially, you got to think of it, this ligament, it binds, it's just essentially binding the big toe to the rest of the foot. And when it's divided, you get a small gap there. So it may be enough, there may be enough room when I operate and explore the ligament, I can get a freer dissector, which is probably about 1 millimeter wide between the two, but there's no resistance. It just flops in between the two. You're not going to see a major change on an X-ray unless you get the high energy Lisfrancs that you get in the motor vehicle accidents. So the X-ray changes may be very subtle. People talk about weight-bearing X-rays, and you may see, again, widening and comparing it to the other side. For me, you can get as much information just by looking at their feet and listening to the stories. A lot of the elite athletes that come to see me will usually have the injury on their phone. So and that includes, syndesmosis injury. I'll be able to see the injury on their phone, and that helps a lot. But I think for people to diagnose, you've got to think about it first, then look at the patients. Obviously, you want to look at both feet. Again, do simple clinical tests, get them to walk on their toes, do the piano key test. Don't be misled. If the X-rays are more than likely, it's going to be very subtle, and the report's usually going to be wrong. So a lot of the elite athletes that I'd operate on, though, will come with an MRI without an X-ray. Okay, so that's just the way it is, and the sports doctors will have them MRI'd within 24 hours of the injury, and they'll have it diagnosed. So it's very important, though, for the listeners to work out that you're dealing with a spectrum. You're dealing with an injury that may be just one ligament, which is the Lisfranc ligament, can be partially or completely torn, or you've got the high-energy injuries where you've got dislocation of the tarsometatarsal joints, you've got chondral damage within those joints. And if you take an X-ray, it's obvious that they're going to have a problem. But having said that, probably a lot of your listeners won't realize that someone who has a high-energy injury in a motor vehicle accident ends up in intensive care, may end up in orthopedic ward for 2 months, 6 weeks, 8 weeks at a time. The thing that stops their rehab 12 months after their high-energy injuries in motor vehicle accidents is usually the foot, because they've been in a coma in intensive care. They've got this high-energy Lisfranc injury, and that's the last thing any of the doctors are usually going to look at. And that's not treated properly, and that's the thing that prevents their rehab. But for what I'm doing now, obviously with the elite athletes, it's a total different ball game when you're dealing with an isolated ligamentous injury.
Mm. And we've seen some research recently come out in the last 5 years around, ACL surgery versus first non-surgical management. Is there ever a case at all, depending on the grade with a Lisfranc, for someone not to have surgery versus have surgery? I mean, all the cases that we have seen have all had surgery, but I don't think I can recall one that I've seen where they haven't. Have you ever
Yeah.
suggested someone go through some normal rehab and see how they go? Does it depend on the grade? What factors play into that?
Yeah, absolutely. Because if someone had an MRI and they said the interosseous was intact, so say the dorsal ligament and some of the capsular structures in that area were torn, and they might have bone bruising or might have some fractures of the bases of the cuneiforms on the MRI, then I would definitely, and I felt clinically they weren't that unstable, then I would treat them non-operatively. In terms of research, the paper that I published in the American Journal of Sports Medicine in the elite athletes that had isolated Lisfranc injuries that were unstable. Now, two of those patients, one was actually an Origin player from up your way. He had played 5 months with a complete tear of his Lisfranc, but he didn't have any pain.
Wow.
So what they did during the season was tape him, bind him up. But his main symptom was instability. And because he didn't have pain, well, they felt that they didn't really have to do anything. And I agreed with them. And then during the off season, I stabilized him with the interosseous device. And he then played Origin, 4 months later after that. So in the other series in that group, there was a ballerina that was treated, again, initially non-operatively, not by me. And then she came to see me probably 6 months after her injury, and she was unstable. So pain wasn't the main problem. It was more that every time they go up on, and particularly being a ballerina, go up on point, she felt like foot was going to give way. But yeah, there is a case there. You're dealing with a spectrum of injuries, and there is a role for conservative treatment. In terms of conservative treatment, I would initially, you want to get the swelling down, probably put them in a cam walker boot. As far as loading it and weight bearing, you would decide at what point you're going to let them weight bear, and then you'd monitor them. And then if they got through that period, then you're obviously going to look for a cushioning orthotic basically in the shoe. And a lot of the shoes around at the moment are amazing in terms of cushioning and support. I mean, there's been a huge change in shoe wear in the last 5 years in terms of what you can achieve in terms of stability, rigid soles, and cushioning.
Was that dependent on their grades, the ones that were treated more non-operatively or conservatively initially? Was that dependent on their grade or their symptoms, or a combination of both, like
obviously.
tear or...
See, I'm not going to usually see I may see an acute injury where I decide not to operate, but a lot of the ones that we published, there were 7 patients, they're all elite, most of them NRL people, but 2 of the patients that had conservative treatment, I'm not sure on what basis they decided to treat them conservatively initially. Again, from my point of view, the MRI, if the interosseous is torn and they're unstable, then I'm going to stabilize them.
Mm-hmm.
I want to give you a clinical scenario. If somebody comes into the clinic on their initial appointment, they play sport on the weekend, and you've gone through your battery test, and you are suspicious of a Lisfranc, and let's say a more severe one where that interosseous ligament is damaged or ruptured, what would be your kind of on-the-spot advice for physios and podiatrists and chiros and doctors? Is it a matter of going into a boot or going complete non-weight bearing, getting bilateral weight bearing x-rays and an MRI, or straight to the sports doctor who will then liaise with the specialist?
I think if you're thinking they've had a Lisfranc injury and your initial management is obviously get the swelling down, you want to make them comfortable. If you can got access to game readers or anything that's going to get the swelling down as quickly as possible, that's a good thing. Make them comfortable, and then you've got to go through the process of re-examining and deciding if you're going to get weight-bearing x-rays is always a useful thing. I think in the first instance, again, in the elite world, the first go-to investigation is usually an MRI. MRI is a better test. There's no doubt MRI is a way better test than a weight-bearing x-ray in these patients who have these isolated Lisfranc ligament injuries. But if they can, the first thing is get them to think about it. Once they've thought about it, start the initial, RICE treatment, get them in a cam walker boot, provide support, tell them not to have the boot on too tight, particularly with the straps. It's not uncommon to get problems with compression of the nerves. The nerves are already stretched on the dorsum of the foot with the bleeding, with the swelling. So talk to them about that, and then go through your process of, in your situation, I would say that probably x-rays first, and then if you're still not happy, you still think that's what they've done, you need to pretty much get an MRI asking the question, have they torn their Lisfranc ligament?
And if there are long-term complications, if it is misdiagnosed, I mean, of course, running into rehab problems, and they probably won't improve very much to a certain point. But are there any long-term problems if they aren't, made surgically and they are quite severe?
Yeah. So, I mean, if the ligament doesn't heal and that hasn't been diagnosed, the ligament doesn't heal, there's issues with instability in that area. You lead to biomechanical changes across the TMT joints in the midfoot, and that can then lead to arthritis, similar to undiagnosed syndesmosis in the ankle. They're very similar in that you can end up with altered mechanics, and then you get joint changes and arthritis in the midfoot. I think it's important, though, the high energy injuries. What's amazing, when you operate on the high energy, motor vehicle accident type Lisfrancs, when you get in there, the joints, there's articular cartilage damage within the TNT joints, and that's why a lot of them will, no matter how well you can reconstruct their midfoot, they'll go on to develop arthritis anyway.
Are you seeing a lot of these people later on in life, like 5, 10, 15 years with arthritis, if they are high energy ones?
Yeah, any intra-articular joint that's damaged, you can, no matter how well the surgery goes, you can end up with arthritis. It's variable in terms of the onset. It's a bit like, having a calcaneal fracture intra-articular, where you can develop arthritis within 6 months or even, 20 years later. Same with snowboarder's fracture. You can see patients develop arthritis. I've seen that. Similar injuries, hard to diagnose on x-ray sometimes, and it's amazing even with that injury, when you look inside the joint, you can see where all the joint's been compressed and the articular cartilage has been damaged. I think people, obviously, with the work that I do with the chondrocyte transplants and stuff in the ankle with talar domes, they don't appreciate, especially trauma surgeons don't appreciate articular cartilage probably as much as they should.
Yeah, that's super interesting. With the surgeries, there's been a little bit of a shift, or maybe a development towards using more of like a tightrope situation opposed to the plate, which was later then having to be removed. What's the decision making in deciding whether you go down one route or the other, or is the plate no longer necessary? Can you just do the tightrope, or does it again depend on the severity of the injury?
Yeah. Well, certainly, so let's stick with, because you're sports medicine, so stick with the elite athletes. So they're usually an isolated ligament injury. So for those injuries, say in the past, they would, similar to the syndesmosis, use a screw, and the screw would go across from the medial cuneiform to the second metatarsal. If you had the screw, then you wouldn't be able to put weight on it generally for 3 months. And then you had to take, and then you had to take the screw out. Then you took the screw out, so that's another surgery, and then you started the rehab. So that essentially was a 6 months out of action. So the intraosseous suture devices, not allowed to use tightrope because it's commercial product. It's a bit like sort of Heinz sauce or PMU sauce, but so that sort of device, right? It looks like a Nutrigrain and a button, and it's got 4 strands of material that between the 2 bits of metal. So when I started using the tightrope device, just like within the syndesmosis injuries, what it means is I can fully weight bear them within 4 weeks. And we published this in this American journal on all the elite athletes. And then they're starting physio. I get them in the pool. If the wounds are okay, they're in the pool at deep water running at 3 weeks. They're full weight bearing in the Cam Walker boot at 4. And we want them pretty much getting going. And the physios will send me WhatsApp videos of them training. And then week by week, I'll be involved in trying to push their recovery. And we published that we now get them back playing, elite athletes, that is, in anywhere from 12 to 16 weeks. Whereas if you look at the work from Calder in the UK with the soccer players, his work, they were similar group of patients, again, comparing apples to apples, was sort of 26 weeks using screw device. So So essentially you can halve the return to play in that group of patients. Now, when you get into the high energy injuries, then you're starting to use plates, and you can use plates that basically bridge the joints, and then you go and remove them. You use everything that's available in those injuries because you're dealing with a very unstable situation involving the transverse arch of the foot. So in that situation, still you may use plates and then go and take them out, or you may not take them out, depending on the situation. But the big thing is the screw, like in the syndesmosis, putting a screw across with the ankle, where you couldn't put weight on it for 2 months, and then you took the screw out, and then it was a 4-month thing. Now I can get people back in 5-6 weeks at NRL, using the tightrope or interosseous device. So,
and for orthopedics, does that come down to just the availability of what they know, or their history of what surgeries that they've done, or just confidence doing the surgery? Because it sounds like it would be pretty clear to not use the screw and use the other option, but what is usually guiding?
I think it takes, obviously because of the work, firstly, you've got to publish your data, which you've done. It's important always to go back to research. And if people want to look up, there's a hell of a lot of work done now on looking at all the work published with using these devices on Lisfranc and how you can get back a lot quicker compared to the screw. As far as, you wouldn't be advocating for people to do techniques that they're not familiar with, I think. And like anything, things takes a while to get across to the mainstream. It's a process. So I think in terms of technique changes, particularly for the athletes, the public health system in Australia doesn't really deal with it can't really deal with acute injuries in elite athletes. So they're dealt in the private sector, but you're basically using, the technology's changed. I mean, it's changed a hell of a lot in the last 25 years. And with those changes have led to improvements in outcomes. So, but that will filter across mainstream.
When you're doing the surgery, and you're obviously, within that area, are you commonly seeing the imaging relate to what you're seeing inside the foot and the ankle? Like, is there a pretty good matchup, or you're going in there and it's usually a lot worse, or it's a lot better?
Yeah, MRI, I think MRI is generally the best if you're talking about investigations and stuff, but it's not uncommon. For example, even with the sinners, I can have a patient where I'll do the arthroscope, confirm that everything's unstable, put the tightrope across, but they're going to have we know that 86% of patients with syndesmosis injuries have chondral damage, and the MRI may not pick that up. And that's the important thing with MRI, is you've got to know about its limitations. It's the best available, non-invasive, but looking in with your own eyes is a hell of a lot better than that. So again, working also with musculoskeletal radiologists, obviously they're going to have a better handle on things than just a general trained radiologist. Again, it all depends on expertise, but so you've just got to be careful. I think for your listeners, if clinically they think, say, for example, there's a Lisfranc injury and they're not happy with the imaging or the reporting, then you've got to follow your own instincts.
Is there any considerations from a rehab perspective after I'm going to call it a tightrope injury because that's the first word that comes to mind. Right. But is there any particular considerations that you need to be aware of in the earlier stages? For example, like after an ACL reconstruction, you need to give that graft site that time to mature. Is there anything like that we need to be aware of, or is it once that non-weight bearing time period is up, you're free to sort of push as tolerated?
Yeah, I mean, that's a good point. So the thing about the devices that we've got available, a lot of people there's a misconception that you're relying on the device to provide the stability. What we're doing essentially, an internal brace or interosseous suture device, what it's doing is providing a milieu or an environment to get the best possible outcome for the ligament to heal, because the forces are acting in the opposite direction. So what you're doing is you're putting in the device, and then what you're wanting then is give a reliable or predictable course so that the ligaments heal, which we know would usually heal over a 2 to 4 week period. And based on the biology of the ligament healing, then we can be more aggressive with the rehab. So in Lisfranc, what we would do is after 4 weeks, they're fully weight bearing in the boot. they're already getting out of the boot and get their ankle moving with the physios. But then I would be getting them in the pool, and then also starting to work in with you in terms of, you might get them on Alter G, again, working on the swelling. They may tend to get a bit of joint reaction, so you use anti-inflammatories, but you would just generally progress them week by week, depending on how they respond. The stability issue is once that ligament's healed, then the device, just like with the screw, it's superfluous. It's the ligaments that are providing the stability, not the device.
Mm. And are there any risk factors? I've read a couple of papers, potentially, foot type, maybe if you have a more cavus foot or a shorter metatarsal. Are there any consistent risk factors you see that may increase your risk of either a Lisfranc injury or potentially infecting the rehab?
Yeah, I think cavus feet generally, there's a lot of stuff now. If you're an athlete, I'd much rather have a flat foot than a cavus foot.
Mm-hmm.
They're tight. They're going to have tight tendon Achilles. They're more prone to getting plantar fascial issues. They're more prone to instability, ankle, peroneal tendon tears. I mean, they're just and tight. So I think, you've got to work in. One of the things that, in terms of being, if you're involved with physiotherapy or rehab, one of the things I'm often telling the patients to go back and tell their physios is, if they've had an injury and they have been inactive even for 2 weeks, then if, say, it's their left side, then every muscle group on that left side from the waist down is going to be affected. So they've got to rehab. You can't just focus on the foot. You've got to focus on their thigh, their quads, their glutes, and work in with that, because it only takes, in an elite athlete, you're looking at about 4 days before they're starting to get muscle atrophy within 3 or 4 days. So, and the other thing is getting tight. I don't think, if you look at a lot of the hamstring injuries that are occurring now, NRL and stuff, you start to wonder how much time are they putting into stretching. I mean, if you look after dancers, most professional dance companies will stretch 20 minutes before they actually get on the floor every day. And you know how flexible they are. So I think, we could do a lot more in terms of focusing on stretching. But in the rehab, I think it's important to be a bit more holistic, look at the whole limb when you start that, and then work in with your surgeon or your sports doctor. I think working in is very important.
That's not good news. Kelly's got the highest arch foot on earth, and I'm a bit more flat, so
and that probably had everything that you rattled off. I've had like plantar fasciitis, Achilles tendinopathy, recurrent ankle sprains. Doomed.
Yeah,
I'll be knocking on your door in a few years' time.
So you just got to do a whole lot more with stretching. But I mean, the shoe wear is important too for you, right?
Yeah. So do you, like the cases that you are seeing, are you recommending, as you said, usually stiffer rocket-soled shoes, especially through the forefoot, and we have so many options now. Are you recommending foot orthoses in through there as well, relatively stiff devices? Are people coming out of them in the long term, or is it something that they always wear for the next 12 months or 18 months? What's your advice there?
Oh, you mean without injury?
Yeah, with all these strength and then supporting the midfoot and things. Yeah,
I think you would basically, I mean, you'd want lots of cushioning, and shoe wear is important for them. It's a serious injury, and even if they get a good outcome, it's probably something that you want to then ensure that they don't go on to develop any further changes. So that's long term. I think that's a good thing.
Yeah, and you mentioned just before, if you see some chondral damage, what are you doing for that when it's intra-articular? You say you have some different techniques or potential treatments for that if there's articular cartilage damage?
I know that's in the ankle, say, for a talar dome, large talar dome. One of the things I've been doing for nearly 20 years and involved with in the International Congress research for particular cartilage damage is we have, chondrocyte transplanting for large defects that fail, microfracture or debridement, same thing. But that's a different issue. But in the midfoot, what the important thing is, what I was trying to say is, you get someone with where the engine basically goes through the floor of the car, their foot gets stuck, and there's nowhere for the foot to go, and basically the TMT joints are completely disrupted. Well, when you actually operate on those patients and you look inside those joints, so even if you put the foot exactly the way it was before their injury back together, they're going to get arthritis, because you look inside, there's bits of articular cartilage that have fractured off, and you're washing that out at the time of the injury. So you know that they're more than likely going to get arthritis. So in those people, there's for example, someone who comes off a building, or jumps off a building or whatever, and they fracture Lisfranc, a high energy injury, and particularly work-related injuries, there is a case to doing primary fusions in that group. Again, it's not your elite athlete type patient, but because of essentially they're going to develop arthritis, have ongoing problems with pain. So there is enough in the literature to support probably primary arthrodesis of the TMT joints in that group of patients. So,
is there a downside to performing the fusion early? Like, I imagine that would be quite restrictive from a functional standpoint in some scenarios if they were involved in some sort of like running-based sports. So would you try to put that off as long as possible, or do you think that there is a place for doing that as the first line intervention?
Yeah, I think the role for the fusion is, these people that you're fusing, they've either got established arthritis. The role of primary fusion is someone with a high energy injury. You jump off a building and you basically want to get them back to work. And so instead of doing 3 or 4 surgeries, you can do the primary fusion and get them back. But generally, someone who's got arthritis in the midfoot, I mean, you definitely, fusion is the last option. You're looking at orthotics and shoe management first, gait training, anti-inflammatories, and most people that I would fuse their midfoots for arthritis, where say the joint's just worn out, they might be in their 50s or 60s. Those people are fairly, their quality of life's not great and their pain profile's high and they've failed everything else. They've tried everything else. For those of you that don't know, when you go through a midfoot fusion, then there's 6 weeks non-weight bearing and then 6 weeks weight bearing in a boot. So it's 3 months. They may require bone grafting as well. So it's not a minor thing. But, I'm sure that's a separate subset of patients that you're dealing with.
But you must have read my mind, because I was just about to ask you that question. One of the questions that come through, we put it out on our socials, so it's probably split between podiatry and physio, was the surgical option for midfoot osteoarthritis. I mean, similar to the knee, people just have a low level of a kind of an ache pain in orthotics and shoes. There's a little bit of research for cortisone, but that doesn't seem to work very well for very long. But the midfoot fusion, people wanted to know, what the outcomes were. Like, do people generally get back to a quality of life? Are they better or worse than what they were prior to the surgery? Like, what have you found in your work?
Yeah, so midfoot fusions for the people you operate on generally. So when you do fuse a joint, there's a 10% chance statistically that it won't fuse. And if you're a smoker, virtually it's going to be 100% they won't fuse. So, it's a good in terms of relieving pain. Most of the people, their gait's going to improve, not get worse, because the joints are already stiff. So what you're trying to do is relieve their pain, which improves their walking duration, everything. It's just that it's very difficult. Any patient who has to be 6 weeks non-weight bearing, they can't get their foot wet for the first 2 weeks. They've got to learn how to shower, all that. It's very difficult. It's more after the surgery that's awkward. In terms of outcomes, most of those people, if you relieve their pain, they're very grateful for that. But it's not a minor thing. When you're fusing joints, you can't replace those joints. I explain to people, when you're talking about the transverse metatarsal arch, the reason there's so many joints there is if you didn't have them there, that your midfoot would crack all the time, just like if you're in the garden and you build a stone arch, you've got to have joins in the stone. So they're there for a reason. They don't really move. A lot of patients would be concerned when you talk about fusion that they think their ankle's going to be stiff, and you've got to explain to them that's not going to affect that. It's more about pain relief.
Yeah, you picked a good part of the body. I like to joke with people when I see them as a podiatrist. I'm like, the knee and the hip, and Kelly being a physio, the knee and the hip's easy. It's just one joint. When you get down to the foot, that's where the smart people are. There's so many joints, and the biomechanics is so unique down there.
Absolutely, yeah. It's but it's been fun. I mean, foot and ankle as a subspecialty really only started in the 90s and took off, and to be part of something that was new was great. And most of the people, probably a bit older than you two, would know that I was very pro working in teams, multidisciplinary, with the podiatrists and the physios. And a lot of the research, these days I don't do it as much, but spending weekends lecturing out of Cumberland with physios, and, if you put on a program, they'll turn up, and the podiatrist. So that's a fun thing to do. But the foot, it's as you said, I always make fun of the knee surgeons and the hip surgeons back at St. Vincent's. I can do that with my eyes closed. Yeah.
Do you see outcomes and like on the topic of the knee and the hip, generally the research, and there's lots of research on knee and hip replacements. When it comes to ankle replacement, do you see the literature similar in supporting people generally having a pretty good response, or it's quite mixed?
Are you asking me now? We're moving off onto a different. You asking me about ankle replacements? Is that what you're asking me?
Yeah. We're moving from we're moving.
So now we're getting into the area of controversy. So okay, so at the moment, the state of play at the moment, there's no in the literature. If you look at the literature, and this is an area that most people like me have either done replacements and stopped doing them, but essentially it's not a thing that you just ignore, and it's something that you've got to keep up to date. And obviously, I'm dealing with people all over the world on a regular basis about what's happening in that area. But at the moment in the literature, there's nothing to support replacement over an arthrodesis or arthrodesis over replacement. Okay. But there are differences in terms of, there are a few things that most of the good literature on ankle replacements come out of Canada. The amount of movement you get with an ankle replacement is probably not that much more than with an ankle fusion. There was a study showing that the patients who had the replacement were more likely to be upset with the outcome because they weren't obviously told about how much movement they were going to get. So their preoperative impression was they were going to get all this movement. More importantly, though, is the complications. With a replacement, part of the consent is amputation. If things go bad with a replacement, they go really bad. And and if you're going to do them, then you've got to deal with the complications. And so yeah, if you look at joint replacement in general, hips are the best, then knees and ankles, whilst there are more being done in Australia than there were, say, a few years ago, but there's still no advantage of one over the other, but you've really got to be very selective too with your patients. If you've got a young patient who's active, you put an ankle replacement in there, the hip's not going to last their lifetime if they're, say, 50 years old, let alone an ankle replacement. But then when it goes bad, you're dealing with a massive problem. So, but, to give you a story, when I came back from the States, so a patient came to see me, he'd had an ankle replacement put in the 1970s here in Sydney, and they'd used cement, and the cement, like you get in the hip, it eroded, the cement disease eroded through the medial malleolus, and he had a pathological fracture through his medial malleolus. And I can tell you, to get all of that cement and polyethylene out of there, I virtually used up half of his pelvis in bone grafting. But so they're not new. That's the important thing. And you've just got to be very careful on patient selection. And essentially, there's no evidence still to date that one's better than the other. So.
I guess the other thing, as you mentioned previously, that you do need to be very aware of is as you get to that stage of someone's life where they might be more likely to need either a fusion or a replacement, they might have those other comorbidities such as diabetes or smoking or poor
systemic health.
Yeah, systemic health, which is going to then impact healing, particularly distally. Yeah. So I've got a patient at the moment that I keep seeing these reports coming through for them about a wound that just hasn't healed after a particular foot and ankle surgery, and that needs to continually get debrided because of some of those risk factors. And that's certainly something that you need to be more aware of, I suppose, when we're dealing with the foot and the ankle than potentially the knee or the hip.
Absolutely. Yeah, absolutely. So, yeah, you've got to, I think, patients with it, for example, you're going to be doing, it's ankle arthritis, and the ankle is an amazing joint because when you think about it, the commonest injury in sport is an ankle sprain, and yet ankle arthritis is actually relatively uncommon compared to knee and hip arthritis. So the articular cartilage in the ankle, even though it's only 1 millimeter thick, and the knee it's 4 millimeters thick, is very resilient to aging and to trauma. So generally with people with ankle arthritis, you would be, say, for example, they've got medial wear. Well, an orthotic's going to make a big difference, just trying to offload that. Or if they've got lateral arthritis, you want to put a normal medial longitudinal arch support in, and then shoe wear. So again, all those factors you'd be using, particularly in a younger patient, you're trying to buy them time. If you're going to do something definitively surgically for arthritis, you want to give them as much time, get them as many years out of as possible. And things, it's hard. People get told they've got to lose weight, and they can't walk. It's like a vicious cycle. So again, trying to work around that, it's important. But But you're right. But I think from your point of view, anyone with comorbidities and stuff, yeah, and they're being advised fairly major surgery, you want to sort of make sure that you talk to them and try and exhaust all the conservative measures that you can, I think.
Do you see the role for any injectables or pharmacologicals in any of these conditions, like the midfoot or the ankle or anything that you're doing or seeing that is becoming more popular?
I think intermittent use. Some people come and see me and they haven't even started taking, say, for example, anti-inflammatories. So I'll say working with their GPs because some of them can influence blood pressure and stuff. So I'll say go back, right to their GP and say maybe we can start a plan of intermittent anti-inflammatories. Steroid injections, for example, the role of steroid injections can be twofold. It can be therapeutic. In other words, you're looking for a response. Generally, if an injection gives a limited, say, favorable response and doesn't last more than a few weeks, I wouldn't do it again. If it did months, then you might look at it again. But more so, the other role of an injection can be prognostic. So, for example, say you've got someone with subtalar arthritis and ankle arthritis, it's a finger breadth away from the joint, from the ankle joint, the subtalar joint, and you're not sure which one's causing their pain. So I'll get them, say, for example, to have a subtalar joint injection under fluoroscopy. And if they say 80% of their pain goes, then I know the subtalar joint is probably causing most of the problem. So there is, for me, a role with injections. It's more probably on that basis. But generally with injections, I don't think, for example, I found hallux rigidus injections they're not going to help much. And I don't use things like Synvisc and stuff in the ankles. I don't use that sort of stuff.
Yeah. Is that just because it doesn't seem to work? I mean, some of the literature is divided on like PRP even or Synvisc for the knee. And I've seen a couple of people get an okay response, but again, doesn't mean it's great, but just the response in the ankle just doesn't seem to be as good. Yeah.
I mean, I think at the moment, more often than not, people will ask you about certain things. And if I don't know anything about it and I have it, I can go and look it up for them and stuff. But generally, if I don't know, well, then I'm not going to recommend something I'm not aware of. But the role of injections generally, even in the midfoot, say someone comes in with arthritis in the base of their second TMT, which is not uncommon. And there's a role for that. One, see if they get rid of all their pain. And two, you might get lucky and it might give you've just got to explain to them. You don't know what the response is going to be until you do it. I tend to use get it done under fluoroscopy because say they come back to your office and they say the injection didn't work, didn't do anything. Usually they say it didn't work. And you go, hang on a minute. Well, let's go through that. So if it didn't give them any relief and they've had it done under ultrasound, I don't know if it was because the guy was or radiologist was in the wrong spot. Whereas if they do it under fluoroscopy, I can see an X-ray with some dye in it, and I know the needle's in the correct spot. So if it doesn't, say they don't get any positive effect, I know that it was because it just didn't work rather than it was in the wrong spot. So there's that issue. So I think injections, there's a role, just depends on what the pathology is.
I have one more question for you, Martin, and probably would have been a better one to ask earlier on, but it just got missed in the list of questions that I wanted to ask you. So we've spoken about the common injuries either being during a sport or those high energy injuries. What actually is happening to the foot for the clinicians listening who are taking a thorough history from someone who might not have footage of the play or the particular incident?
So the mechanism.
Yeah, the mechanism of injury.
So if you look in the sport sort of context, generally their foot is slightly plantarflexed, in a slightly plantarflexed position, and you may get an abduction force applied to it. So in other words, it's a twisting motion. So as you know, all the Lisfranc injury was originally in a horse. Lisfranc was a surgeon in Napoleon's army, and their foot got caught in a stirrup, and so it was a twist. So there's that twisting moment with the foot. It's fixed and it's slightly plantarflexed, and there's a rotary force applied to it. So that's important. With a high energy, it's usually, if the engine of the car's coming through the floor and your foot's got nowhere to go, well, that's pretty obvious how that's more of a direct force. I think it's important, probably for your own listeners. I'll give you an example. And you'll like this. So when I published this paper on the elite athletes in the American Journal of Sports Medicine, so this lady came to see me, and she was an equestrian. She competed in equestrian events and stuff. And anyway, she sat down and I said, "You've got a Lisfranc injury, that I'm going to use this tightrope device." And she went, "Oh, fantastic." I said, "What do you mean?" She said, "Well, I've got your article." And I kid you not, this is a month after it was published. She had it on her phone. And she said, "I read your article and I thought, oh, maybe because I'm not a footballer, you won't do that surgery on me." And I said, anyway.
I feel pretty famous. Pull out the article like a fan.
So, no.
Yeah,
And
she's
so,
done her
but to give you an
research.
idea, I tell people when I was at Royal North Shore as a resident in the orthopedic department, the professor there, Tom Taylor, he paid extra money to get the orthopedic journal sent to him from England and the US, but it was still 6 months after it had been published.
Wow.
So that's in the 80s. So to give you and here's a patient who walks in with she's got the article on her phone a month after it was published. So you can see the value of what you guys are doing and technology and, people's access to information. I think it's very important. So, I'm a big fan of Dr. Google. I know doctors poo-poo it, but, I've got a daughter and a son-in-law work at Google, but I think what it's done is it's empowered people, given them the information. And unfortunately, there's a lot of misinformation out there too. So,
yeah, that's why when coming to do this podcast, we always look around to see what other information is out there. We couldn't find anything at all in video or audio format from someone qualified to speak about Lisfranc injury. So, and we've had lots of people ask us, so it's great. We really appreciate you coming on and offering your time.
Oh, that's fantastic. No, I appreciate it. Even though it's Saturday afternoon, it's like
Yes.
Nothing more you'd rather be doing.
I know. What else would you rather do on a Saturday afternoon?
Saturday afternoon. That's right.
Now, we wanted to put two last questions on you, and we purposely don't put this in the list of questions, but you don't have to answer them, of course. Question number one is, if you could speak to anyone on earth, dead or alive, who would it be? And then secondly, if you could conduct any research, funding, ethics, nothing is limited, what research would you do?
So if I could speak to someone dead or alive.
Yeah, anyone. Like you just chat with them, have dinner, anyone you would like.
Probably Steve Jobs.
Steve Jobs. That's a good one. That's good.
What would you talk to him about?
Lisfranc
very personal. That's very personal. No, it's funny. I do like reading biographies of various people. And he's slightly on the spectrum, but interesting at the same time. Same with Elon Musk. If you read his, it's fascinating. If you read his biography, there's a photo of his brothers and sisters in the desert. They're somewhere in South Africa as children, and they're all, and I tell this to my kids and stuff, they're all outside this caravan. They're sitting there and they're all reading books, all of them. It's just what just tells you, So that, but what was the second one about research?
Yeah, so you're able to do any research you like. Funding is not an issue. Recruitment isn't an issue. Ethics isn't an issue as well, which I know is very important. There's no limitation at all, and you get to do anything that you want, study anything that you want. What would it be?
You mean in terms of what I do?
Yeah.
Like a question that you want to ask from a research perspective where there's no limits.
Yeah, from the ankle, of course.
It doesn't necessarily have to be foot and ankle.
Yeah, it doesn't have to be foot and ankle.
It doesn't?
Anything in the body, I guess.
Anything.
For me, I've got two nephews who've got cancer, and so
cancer research.
That would
cancer
be
research, especially
absolutely
for young people. I've got a nephew who's involved with myeloma as the advocate for young people with myeloma. So there's not enough money.
No, not enough money.
Not enough money and not enough time, especially when you're young.
Especially and researching kids, I think there's a lot of ethical qualms as well. So overcoming that is always a little bit tricky.
Absolutely. So no.
Right. Thank you so much for coming on. We really appreciate your time, and thanks for giving up an hour of your Saturday afternoon. We really appreciate it.
No problem. It was lovely to meet you both.
Lovely to meet you too.
Okay, thank you. Bye.